Okay. Hello, everybody. I'd like to welcome you to our RHC webinar today. It's entitled Value Now at ACO for Your Rural Health Clinic. And we're very lucky to have Charles James Jr. here with us. He is Executive Director of the Rural Advantage ACO. It's very timely because you have until August 1st to get signed up with an ACO if you plan on participating in one starting January 1, 2024. So time is of essence. I can say that eventually. So Charles is here and he's going to give us a presentation on ACOs, and maybe you want to join up with Charles's ACO. That would be a good thing. Here's from a commercial standpoint, HBS. I'm with Healthcare Business Specialist. My name is Mark Lynn, and we do RHC cost, a bunch of them this year. Way too many this year. It seemed like it was a rough cost reporting year. Let me tell you, there was a lot of them, and cost reports are a lot harder than they used to be. Charles's group, their North American Health Management Services, they do a lot of them as well. David James does cost reports as well. So those are a couple of things there. Program evaluations, if you haven't done your program evaluations, they are due every 2 years. You want to make those. Those are some of the things that we do. I won't spend too much time. Here is our team. My plan is to retire October 31st, 2024. And so Paige Chambers, Trent Jackson have come in to help Danny Gilbert, who is our partner, and she'll be taking over there. So that is sort of the plan. They may keep me on a little bit longer, but the plan. If you've not joined our Facebook group, you can ask questions. Charles will answer them for you. Patty Harper, several people, Deanie, for you on there, and other people will give you their experience as well. So it's a really good place for you to exchange information. If you want to put information on there about your seminars and webinars, that's fine. We're happy for you to post stuff like that. That's informational for clients. We don't really like it if you're just advertising services and not that sort of informative stuff. We tend to not let those go on there. If you do know our website, it is ruralhealthclinic.com. So if you want to go there and find information there, there's a question box over on the side. If you will, just ask your questions there. Hold them till the end, and then we'll answer one time. That would be great. Disclaimer: I'm assuming that Charles has got this thing updated as of today, so it can be. All situations are different, so yes, about this, Charles can answer those, or you may want to email him as well. There's Charles's mug. He said Charles James Jr., and we were just talking for both been doing this for 30 years. Charles was just a pup when doing back then, and he's grown in. I'm like a proud parent almost, where seeing how well Charles has done over the years and working with rural health clinics. He's been the past president of the National Association of Rural Health Clinics. He's worked with RHCs now for at least 30 years. They do a lot of billing. Like I said, his cousin David does a lot of the cost reports, and they work well together with that. So that's all I have. Now I am going to turn this over to Charles and let him present to you. And okay, why is it not letting me make you a presenter, Charles? Oh, there we go. Are you on there, Charles? Are you doing the present? Are you in charge now? Okay.
I think so. Can you see my
very good. Off to you, Charles. I'll get out of your way. Thank you.
Okay, good. Well, thank you, Mark. Extremely generous in allowing us to come on and participate in his forum. Indeed, not only have we worked in the same space for a long time, we've collaborated on many different projects together. And indeed, we came, and Mark was generous enough. David would come to his old seminars, and really it helped us start our business. So we've been around the block a few times, just like Mark. New folks coming in to supplement Danny and keep healthcare business specialists alive, because I know many of you rely on the expertise you receive from them, and many of us that did with one another. So the great thing about today's forum is that I'm not really, in most of our NRHC things and state associations we go to, of course, can't just explicitly promote. I'm not here to just promote Rural Advantage, but I can be a little more explicit in asking you to say, hey, to hopefully educate you on what value-based care for RHCs and FQHCs, and to, yes, ask you to come with us as participants. My date's a little out of whack. I've given many different versions of this presentation. One of them, I kind of felt proud of maybe in a sick way, my multitasking. I gave probably about 2 weeks ago from the NRHC fly-in. I literally found a closet, an old telephone booth closet in the Capitol building between visits, where we were advocating for the RHC burden reduction, and gave a version of the same presentation. Most of you know me from North American. We established Rural Advantage in order for really us to be able to help guide our clients into the value-based world, because this is a whole different language and science, and we've got to have a really deep understanding of rural health clinic billing to be able to succeed in this. And with many weaknesses I do have, one strength we have at North American is certainly our technical expertise on rural health clinic billing. So that's what we hope to, I hate the word leverage for our clients as all of us enter into this value-based world. So our Rural Advantage is not restricted to North American clients by any stretch. It's not restricted to rural health clinic. But what we find is, in the value-based world, as this rolls out, we know that rural health clinics lost down in the weeds of all of the other programs, because in many ways we're such a small part of the Medicare program. Just like EHRs, when EHRs came out, your EHR vendor would tell you, or your billing company would tell you, yeah, we understand rural health clinics. And it's the same of ACOs. Yeah, we understand rural health clinics. But then everybody becomes surprised when we lose attribution because our annual wellness visits didn't get billed correctly. So there are those types of things that we have to be really careful of in the value-based care program. CMS introduced, and the quality payment program came about as a result of the Affordable Care Act, all the way back in, 2000. I can't tell you what year the Affordable Care Act is. I should know better than that. But the Affordable Care Act, otherwise known as Obamacare, did create payment for preventive services and a long-term objective of totally refocusing the Medicare reimbursement toward outcomes and away from fee-for-service reimbursement. The goal, we've heard this before with HIPAA, for example, was to decrease provider burden. Some of us are always a little skeptical when we hear that, and preserve independent clinical practice. We've also seen a great erosion in independent clinical practice because so few of us anymore are independent providers. We work for a large corporation in many circumstances. Those of us that don't, or rural health clinics that may be very small, get totally lost in the weeds of many of these programs and get lost way down at the bottom of the food chain. So hopefully, part of what we're doing changes that. Alternate payment models are what we're talking about. MIPS was an alternate payment mechanism. ACOs, value-based care, shared savings, these are all different ways to describe alternate payment models. And the objective is no less than reform of the health system. We're looking to transition to a new system and away from fee-for-service and towards quote unquote high quality, efficient care. We'll see if we can get there or not. Those are the program objectives. You've all talked about risk. That's one of the first questions I get. What about risk? Part of the whole objective is to transfer risk. When we transfer risk and responsibility and accountability from only payers to providers and to patients. We're talking about transferring risk. Whenever you hear, we're largely talking about transferring financial risk away from payers to providers and to patients. Patients increase their risk because they have co-insurance and deductible amounts. So that's their skin in the game. Kind of like our rural health clinic. We kind of have some risk base because if we don't make our rate every year, if our costs, if our cost per patient drops, which is a perverse incentive, but if our cost per patient drops, we're at financial risk because we've already been paid. So assuming our rural health clinic reimbursement is a poor example of that. But when we talk about risk, we're talking about am I at financial risk of having to pay something? The lowest risk where we see shared savings all the way at the left-hand side of our screen. Shared savings, track A, is an entry point into the spectrum of risk that involves upside only, which means you only get to, you participate in shared savings, but you don't get penalized if you don't make things. So upside only means I'm only going to share in the benefit, but I'm never going to have to pay something out. And one would expect the lower the risk, the less the reward. We go all the way to the other end of the spectrum when we talk about low capitation. Your Medicare Advantage plan, insurance payers are effectively capitated payment programs. The sense that insurance payer, your Medicare Advantage plans, receive a lump of money to take care of each of their enrolled patients. Here, Optum, United, $12,000 for Mabel Jones patient care for this year. Spend it well. And then the payer pays out hospital visits, diagnostic tests. The payer is at one risk on, now not 100%, but that global capitation, if costs exceed what they've received, then they're the ones at risk. So that's all the way at the other end. Another great analogy I like to use is for shared savings is something like, if we want to use an investment analogy, like 401k matching program for your company. You're in a company that 401k matching, you put in 3%, they put in 3%. It's kind of like that. All the way towards a global cap, that would be, we're talking about high level bond trading on, the international market, for example. Have heavy downside financial risk in that situation. Everyday investors would never start out in something like that or participate in something like that. We're at the nice, safe, cushy matching program down at the low end of the risk. And that's the way we get into this program, is we start to learn the language by participating in the lowest risk product possible. Just like investing in mutual funds, kind of the same thing. Low risk, typically, I don't want to get into the downside part of the mutual fund, but you get my point. It's a very similar analogy. Savings creates the terms an accountable care organization that applies for Medicare shared savings as that organization, so then any of their participants in that, on that list, are then in that accountable care organization to participate in shared savings. Here's the misnomer. We're used to, in a rural health clinic, talking about our cost per clinic, our cost per patient. what are our costs in our clinic, we're not talking about reducing our clinic costs. We're talking about what is our attributed patient cost to the program. What is each of our costs to the Medicare program? And the objective of Medicare shared savings is to reduce that cost of my patient attribution population, the patients that my clinic is seeing, and reduce their cost to the program. How do we do that? Preventive services. Medicare tracks that via claims. The reason that we all join an ACO is because you have to have a minimum of 5,000 beneficiaries across the ACO. So for us, Rural Advantage, we right now have 31 participants with over 10,000 beneficiaries. Some of those participants have 1,200 Medicare patients. Some of them are little nurse practitioner 20 patients. And what I will tell you is take your best guess of how many Medicare patients you have and multiply by 0.3. You have approximately 30% of the Medicare patients that you think you do. And there are a variety of reasons for that, mainly related to this whole voodoo of patient attribution. But track A and B, Medicare shared savings, you are now in an ACO that has, among all of these participants, more than 5,000 beneficiaries, and we're going to share savings with Medicare at 40%. We share 40% savings rate, and you see that shared loss rate, bullet point 3 under basic track, hand side of the screen. Shared loss rate is 0. So when you, right now, for example, Rural Advantage is at track A. We're going to stay at track A for a while. We're going to participate in the upside. We're not going to take on downside risk. We can see if you move to track C and D, there is a shared loss rate, but the savings rate is higher. I don't understand a lot of that stuff behind basic track C and D because we're not there yet as an ACO. Many of us in the rural health clinic market have participated in ACO, and some of us would be prepared to take on that level of risk, but most of us are not. And then when we see up to basic track E, the shared loss rate gets higher, and the enhanced track, when you start talking about ACO reach and direct contracting and some of those other models, those were up at that track E and enhanced track. And most of the folks you're talking to were down at basic track A, entry level, vanilla stuff. Here's basically how it works. Our goal in Medicare shared savings is to reduce total cost to the program. So at the micro level, what happens is I see Mabel Jones has gone into the hospital. And Mabel Jones was hospitalized for a heart attack. We call Mabel Jones and we say, Mabel, you're our patient. What happened? We need to see you after you come out of the hospital and before you transition to the nursing home or back to home, we need to see you. Everyone's maybe catching on to the fact that's a transitional care management service. That individual call and patient visit saves the Medicare program $4,000. We save the Medicare program $4,000 because we've reduced the risk of future hospitalization and we've reduced the potential severity of future hospitalizations because we perform that transitional care management service, and all the actuaries have it figured out that that's what we saved. So we're reducing the total cost to the program by offering high quality care to our patients, a seemingly contradictory endeavor. It's fee for service plus a reconciliation for shared savings. So you go through the course of the year and you just get your same claims payments. It doesn't affect claims payments. And after the first year is over, Medicare does all their math and they say, this is how much you saved the program. Here's a check. So you do not affect your claims. It's claims plus reconciliation for shared savings. As you move up that to direct contracting geographic, and then Medicare Advantage's total capitation, you're moving up the risk spectrum as you take those on. Most of the time, if you're participating in an ACO, your ACO is going to ask you, are you doing care management services? That's how we're out getting outreach to our sickest patients, our frequent flyers, and providing annual wellness visits so that we can document our patient's disease burden and how we've addressed it. A big part of what we're doing, utilization of hospital, ER, and skilled nursing facilities. And that's why transitional care management takes on large importance. Preventive screenings, and then everybody says, well, my patients are sicker than everybody else's patient. And we would say, no, actually, they're not. Because what's happening is all of the providers around you are probably not coding their diagnoses correctly. And we get into this HCC coding. And that is how we report our patient disease burden to payers. And that is an enormous variable, is our own diagnosis coding, and reporting disease burden is a big focus on a new participant in an ACO, because your risk scores are probably low, which means your patients to Medicare don't appear very sick. And we all know that all of our patients in our rural health clinics are very sick. The other thing your ACO is about is CPT level 2, claims-based reporting. More on that momentarily. Patient attribution. How do your patients get attributed to you? You would think if you see a patient, they're your patient. Absolutely not. That is not the case at all. You have many patients that you're seeing that are attributed to someone else. You have patients that are attributed to you, but are probably seeing someone else. So one of the things that your ACO is going to do is push patient attribution data to you. The main thrust of that patient attribution data is so that you can get that patient in for an annual wellness visit, or see them perform the annual wellness visit when you see them, and make sure during that annual wellness visit that you're documenting their disease burden and creating a treatment plan for those. Because here's how it works. If you have a patient that loses a limb because of a diabetic amputation, that limb grows back every year until you report that limb lost again to CMS in an annual wellness visit with proper HCC coding. Oh, this patient has a diabetic amputation. And so every year we have to report our patient's disease burden. That's where the annual wellness visit comes in. And when we do those things, we're hopefully reducing our SNF and end-stage renal disease utilization and our readmissions and ER visits. And we're going to watch all those things very closely from within the ACO. Typically, remember I said that $4,000 Medicare is going to split. Medicare is going to send the $4,000, they split it 40%. So they send the 40% to the ACO. And typically the ACO is going to split it with providers. A lot of ACOs have a 60-40 revenue split. 60% goes to providers, 40% goes to the ACO. Some are 50-50. And again, this track A doesn't involve, oh, provider, you didn't meet your measure, cough up. It doesn't work that way. So this is typically how the ACO makes their money. Medicare pays the ACO. ACO distributes to providers. If you're in a large organization, your organization is going to decide how you get that money. The provider is the EIN. The provider is not the individuals underneath that EIN. What are your considerations as a practice when you join an ACO? It is not cost-free. Our ACO, for example, has no entry fee. We have no downside risk. I'm talking about financial costs there. But of course, we are talking about practice transformation. The costs of joining ACO are actually internal, talking about focusing on quality and outcomes and trying to move away from fee-for-service, pay-per-click. We're talking about practice transformation. That doesn't, that's not just something, oh, we're going to spend 10 minutes and participate in our. No, we're going to start focusing on how do we get annual wellness visits done. Coding education for our providers and HCC coding is an enormous issue, because I can't tell you how many practices come back and they've got a large I was about to use an inappropriate term for patients. Patients are people, they're not a load. But we have large patient volume of people that are sick with many, many chronic conditions. Risk adjustment scores come back less than 1. We know we have a coding problem. We haven't seen a risk adjustment score yet, but when you start talking about those, any risk adjustment score on a provider that is greater than 1 means their patients are sicker than average. And any that are below than 1 means their patients are healthier than average. And I see a lot of rural health clinic providers that come out at 0.5, 0.6, 0.7, and we know, frankly, is from, let's call it inaccurate, and let's call it kind of inattentive diagnostic coding. How about that? Diagnostic coding, the big focus. We have to think about care management, not necessarily just in are we providing care management services or not. It's not really it. It's how are we reaching out to our sickest of our sick patients, our frequent flyers at our ER, our frequent flyers at our skilled nursing and our hospital patient. How do we reach out to those patients and keep them out of those facilities? And so that's what I mean by care management. Let's get that patient who's been to the this year and get them to the clinic and get them on a care plan. Patient attribution is the denominator. I left it at the bottom. It's the foundation of what we're doing. Who are your patients? You're receiving shared savings on the patients that you have attributed to you, not the patients that you've seen, the patients you attributed to you. So if you do an annual wellness visit on a non-attributed patient, that's great. You may get that patient attributed to you, but you're not being paid shares patients seen based on attributed patients. There's a ton of science that goes into that. Annual wellness visits and preventive screenings are standalone encounters, and because of that, we face enormous billing challenges. We don't get paid an extra or line item like the rest of the fee-for-service world does when we do an annual wellness visit, and this removes our incentive from our providers to do annual wellness visits. This is a big problem. We cannot submit CPT2 codes on our rural health clinic Medicare UB04 claims yet. When I go back to that HCC coding issue, that is a big problem. Because if we're in a claims-based program, we're handicapped from properly reporting our claims because our lives would all be much easier. We would have to go mine much less data if we could submit CPT level 2 codes, just like the rest of the world does, when we've ensured that our patient has had their mammogram, when we've ensured that their patient has had their colorectal cancer screening exam, when we've ensured that we've checked the patient for depression, substance abuse, opioid usage. We need to be able to submit those level 2 codes on the claims, and we cannot, and that's a big negative. And if your ACO doesn't understand that, you will not succeed. All of these things do represent. So I'm not anybody that says you just go into an ACO and there's nothing you have to do, just do what you're doing, is not being honest with you. We're signing up now in July for performance year 2024. So what we start doing now is start laying the foundation to start more properly reporting our patient disease burden, finding a way around our CPT code problem, dealing with our revenue cycle and whether or not our annual wellness visits are being properly reported on claims, because everyone has an incorrect perception that we can't submit at the same time as an office visit. Huge disconnect between billing your ACO and what's happening on the ground. And part of what we do at Rural Advantage is try to close that conversation so that we're all speaking with one another. Performance year 2023 is what we're in right now. So at the beginning of 2024, we're going to get data based on this past year. And for Medicare shared savings, you get one payment annually. One payment annually. So all of our folks who signed up probably in the summer of 2022 and were doing all of these things haven't seen a dime yet. Haven't seen a dime yet. And they won't until the beginning of 2024. So you know you're making an investment because you're not going to be paid until a year down the road on Medicare shared savings. You get one payment per year on Medicare shared savings, and it's not until after the first quarter of the next performance year that you finally get that payment. So it takes a while to cook. As of 2020, 40 rural health clinics in ACOs. It represents roughly half, and we've seen a big spike in rural health clinic participation in ACOs. There's that distribution geographically. Let's talk about Medicare Advantage. We know with our rural health clinic programs, our Medicare Advantage plans are all over with how they pay us. Medicare Advantage is a commercial Medicare program. It's a commercial Medicare plan, which allows them to do whatever they want to. So when they tell you they can't do something, that's not true. They can do whatever they want to because they're Medicare Advantage and they make all the rules. And if you think I'm not kidding, let's go back and look at the ACA. And you know what happened in the ACA? I didn't realize this. There's a non-interference clause between CMS and your Medicare Advantage plan. So as long as the Medicare Advantage plan stays within certain parameters, they can do what they want because there's a non-interference clause. And now, of course, I'm exaggerating a bit. But really, the Medicare Advantage plan is its own plan, and they determine their rules. So if they wanted to pay you as a rural health clinic, they could do that. If they wanted to pay you as your Medicare Advantage plan, if they wanted to pay you an extra encounter for your annual wellness visit, they could do that because we know they have the gold, they make the rules. Now, we have a couple cards up our sleeves as the providers. Medicare Advantage plans have grown in their own purchasing power so that we're at the place now where roughly a lot of our participants, 50 to 60% of their Medicare population is Medicare Advantage. The growing Medicare Advantage penetration, and you think about for every one of those Medicare Advantage plans that doesn't pay you as a rural health clinic, they're eroding your reimbursement and preventing us from being paid our full cost per encounter. So the more Medicare Advantage plans we have, the less we can rely on our rural health clinic encounter being paid for a Medicare patient. These value-based care initiatives are one of the places we can take the power back. Your Medicare Advantage plans have a score on you, and the score that they have on you matches the score that CMS. Let me say it this way. The Medicare Advantage plan has a scoring mechanism that they put on you, a grading scale. They're graded on the same scale, exact same scale. So your incentives align exactly with their incentives are, because their incentive is to decrease the cost of the Medicare program of their attributed patients. There are a number of tools out there that our commercial plans are graded on. We're going to talk about it. But basically, they have the same grade that they get from CMS that they put on us. So we can use that to our advantage because now and our commercial plans and our Medicaid plans need us to perform these activities. So all of our Medicare Advantage plans have incentive programs. Most of our commercial payers, the big ones that our practices rely on, have incentive programs. Guess what? Your Medicaid MCOs have incentive programs that they want you to get paid for because then they get paid more money. This is not a situation on all of these other non-Medicare incentives that you've got to wait till the next performance year. This money is available right now. They're largely the same activities, but it's a way to get incentive money now. All of your payers that offer incentive programs probably implement some version of CAPS, and CAPS is a survey function that they go out and they survey your attributed patients to see how well you're listening to your patients, how courteous you are to your patients and respectful you're. I'm down reading the list on the lower right. Can your patients schedule an appointment quickly? Do you get into an exam room within 15 minutes? Do you get your flu shot annually? Do you get your care managed with other providers? These are all survey tools, survey components that our payers ask your patients about you. Are your patients getting needed care? In the last 6 months, how easy was it to get the care that you needed? That's a patient question. How well does your doctor communicate with you? Does your doctor, my mother's in the hospital right now, and she doesn't absorb detail terribly well right now. How often does your doctor explain things in a way that was easy for you to understand? And if my mom's answering that survey question, well, I'm going to make darn sure we spell it out real clearly. My mom's a very intelligent woman who has a PhD. But right now, she suffered some decline. And so we have to be sure that the doctor is listening carefully to what she understands and doesn't. And these are all grades on which the practice is being evaluated. The healthcare outcome is the other component that all of our payers are looking at. All of our payers are looking at HEDIS in terms of the quality of care being received, whether or not appropriate access to care, and whether or not the patients are satisfied with the care that they're receiving. I'm dating myself. I'd like you all to go out, if you don't already know it, and see who Brad Hamilton is. He's a very important literary figure with the infinite words of wisdom of learn it, know it, live it. Those are the rules for entering Brad Hamilton's fast food restaurant, but they also apply to HEDIS and CAPS because we really have to understand our HEDIS measures in order to succeed really with any of these value-based care proposals, but especially with our Medicare Advantage and our Medicaid MCOs, because again, CAPS and HEDIS are the scores they rely on to score you. If you get a copy of this presentation, you can see that, I thought each of these was linked. It may not be in here, but you can go, of course, just get your HEDIS measures using that Googler Medicare HEDIS measures. Make sure 23, they do change a bit every year. They're all of the various testing components that we're pretty familiar with. We're getting bone density measurements for appropriate patients, colorectal cancer screening, eye exam, A1C results, et cetera, et cetera. These are all preventive services that we know that we need to report to our payers that we've done. Our documentation needs to reflect in our medical record that we've evaluated these things. And then when we do all of these things correctly, this is how we get our incentive money. The payers have various mechanisms for introducing these things. Look at the care of older adults. That's why I highlighted this. We're going to take a particular look. Those HEDIS measures are reimbursed by our Medicare Advantage plans. This is directly from Medicare's WellCare's Medicare Advantage plan. This is an Illinois product. So WellCare product, fully cited. You can see the link down there. Go provider.wellcare.com. Here are their incentives for 2023. And look, they go right to the HEDIS measures over there on the right-hand column. And look at that. they're paying $50 every time you make sure that one of your WellCare Medicare Advantage patients has their breast cancer screening. You're not doing the breast cancer screening, you're making sure they've gotten it and reporting the CPT code, and you're going to get $50 for each one of those. If you're missing out on these dollars, if you think about how many of these you're doing for your patients, and a lot of you are probably performing these activities, maybe you're not getting them appropriately documented. You're very likely not getting a CPT level 2 code kicked out on that. And if you submit your CPT level 2 codes to WellCare Medicare and they're on a 1500, they're going to take the CPT 2 code. If you can't get the CPT 2 code because they're paying you as a rural health clinic, for better or worse, you can go to their portal and report these measures. They have multiple ways they want you to report these measures. For WellCare, Meridian, and Ambetter, Meridian and Ambetter are Medicaid MCO products in Illinois that we're getting incentive money right now, available today, right this second. The appointment agendas for your attributed patients, and you can go into WellCare's portal and get the forms needed to submit these various measures to WellCare, and you can do it in their portal in this older assessment form. The perfect example, we're going to complete this form is represented there on the right. This does not have to be a physician or nurse practitioner completing the form. All they have to do is sign it. So the folks that are coming in and quote unquote closing gaps for you, we're submitting a form like this, sending that to your provider for signature, and then we're going to upload it to the WellCare portal. Here's another agenda submission. This one goes to Centene. This one you can't see it very well. Ask them specific questions about diagnoses this patient has presented for and whether or not those diagnoses are still in evidence or whether they're no longer present. We're going to submit that form to the payer. Here's a Centene form. All of these are available right now. And look at the money we're going to get. This is the older adult assessment form. So that if you're completing for more than 80% of your patients, you get that older adult assessment form completed, you're going to get $400 per patient. Per patient. $400 per patient. That's over. For example, if you do an annual wellness visit, you're going to get the annual wellness visit. You do the older adult assessment form, you get another $400 for completing the form. This is where it pays to have a staff person. We're helping do a lot of this. So here's where I'll tell you where we are with Rural Advantage momentarily on this. Look, Medicare and Medicaid bonus. Guess who runs all of our Medicaid programs? Centene. Centene is the backbone of this Meridian product. All of these large corporate plans, you can use that term, WellCare, Optum, UHC, Humana, Centene, they all pay these same incentives right now. Check with them. Reach out to your provider representative. Don't exclude commercial and Medicaid MCOs. They want to pay these. The one way you can get around not having to submit forms to a portal is to close care gap, report the care gap closed, and submit the CPT level 2 code. Start getting in the habit for all payers. All payers. Just start making it muscle memory. We're submitting CPT level 2 codes for all payers. Of course, don't rush out and change your entire revenue cycle. Implement this. Maybe choose one payer to start implementing it for, but all payers want your CPT level 2 codes. We just can't do it for Medicare UB04 yet. Traditional Medicare, we cannot submit CPT level 2 codes yet, but your ACO, we, Rural Advantage, if you're in our ACO, we really need you to have the CPT level 2 code in your EHR so that in the first quarter next year, when we're asked to go do documentation reviews on our patient attribution list, we can go to the CPT level 2 code and the data is there. We don't have to just go read through medical records. So our advice is report CPT level 2 codes for your traditional Medicare patients in an ACO especially, but suppress that CPT 2 code from the claim. Have it in the system, don't submit it on the claim. The claim will bomb if it's on the claim, but if you have it in your system, you can go back and mine the data much more easily. So if it's due, if it's documented, it's performed, report the CPT2 code. Change your thinking, reverse it on that. If you're not getting value-based money, you're missing what's going to become a larger piece of your revenue. And ultimately, none of us are going to be able to survive without it. Part of the point is, and I didn't make it in this presentation, CMS is going to push us all into value-based care somehow. We hope to provide you a choice so that while we can still make the choice, while we're still a voluntary process, I don't know of any involuntary process, but we just can see a future where we get to beyond 2028, where Medicare is ultimately going to push you into a risk pool if you're not already in one. Part of our reason for existence at Real Advantage is to take control of that decision. The reason we put Advantage in our name is because we want to start we are approaching Medicare Advantage plans right now to contract with them so that we can see what kind of per member per year we can get to our participants so that we can get them money on top of what. That's part of the point. If we can, without seeing more patients, we're going to reduce provider burnout. Our goal is to get more money to our participants so they can stop living such stressful lives. In doing so, we promote patient well-being, but our providers have to be well to see patients. That's the whole thinking, and putting providers first in our mission. And we don't want to pay all of the giant corporate heads at some venture capital office. We're returning the value to our providers. I'm the executive director. We have a big team behind us of really qualified people that are the ones actually doing the work. I just talk a lot. Tom Davis is our medical director. Tom Davis came to us from a rural health clinic in central Missouri, and he's already sold his practices based on their value-based contracts that they had more than 10 years ago. Pinnacle, Kelly Conroy and her team helped Aledade. They're now helping us. This is our objective, is to increase revenue without having to just see more patients. Payments are over and above claims revenue. Nothing changes with claims revenue. When you join RACO or Medicare Shared Savings Track A, claims revenue should not change. There's no downside risk. We're tracking some very simple measures. Are you attending educational events? Are you retaining your patient panel? And are you accomplishing annual wellness visit for more than 70% of your eligible patients? Are you doing transitional care management? Those are our measures that we deal with. The information we push out to our participants looks like this. See that HCC risk score, 0.96? So those are moderately healthy patients. I never believe 0.96 risk score in any rural health clinic anywhere. We have more coding work to do. Some of these, if you see a 0.5, coding is a huge problem because we should all be well over 1 with the number of chronic conditions that most of our patients have. This is an example of the utilization information that we're going to push out. This is the per member per year cost, which is how aged ER visits. This is going to be pretty typical information you should probably be receiving from your ACO already. And we're going to track these things so we can reach out to, for example, back here on the ER visits, We're going to get claims data from Medicare that we can drill down and say, oh, November 22, our ER visits were pretty high. Who was driving that? And we can go in and identify the 20 patients that had too many ER visits and pull them in for care. So your ACO should be constantly looking at your patient attribution data to look for savings opportunities. Look at that. Boy, we had a bunch of readmissions. Who was getting readmitted and what is the problem? How do we get them in and stop all those readmissions? You are being measured by all of your peers around you. You're looking again. These patient attribution is the whole key. Are you doing annual wellness visits? Are you reaching out to your providers to provide HCC coding education, and are they engaging with it? Are you engaging your providers to get buy-in? Because if your providers aren't engaged, this will not succeed. And what are your utilization for you? When we say utilization, we're talking ER, inpatient, SNF, ESRD, your facility utilization for your patient population. Your ACO, nor will we ever come in and tell you how to treat patients. We'll talk about how to do annual wellness visits, but we'll work with you. Your ACO should not affect ever the patient-provider relationship. It's just sacrosanct. So for us, we're at 75-25. 75% of the revenue goes to our participants, 25% of the revenue comes to the Rural Advantage. We would like you to come join us. We believe that we've got the expertise to help you navigate this new world. If you're already in an ACO, great. If you're in an ACO and are happy, come talk to us. We can talk about the reasons. The point is, get into something, and especially get into someone who's talking about closing these care gaps. These are available, all of your WellCare, all of your Optum, all of your Humana have these same available incentive programs available to you. That's me. A lot of you could probably find me if you tried very hard. Hopefully we've answered a lot of questions about some of the mechanics of how value-based care is larger than just an accountable care organization. But hopefully you're addressing all payers in whatever value-based proposition you've got. Mark, thank you again very much for organizing this presentation today and letting me speak to the participants, to everybody here. And I hope to speak to you soon.
Yeah, hey, Charles, I think it was great. Thank you for doing this. It could not be more timely. I mean, with this August 1st deadline coming up on us, to me, it sounds like there's a couple of tracks that our RHCs need to go on. Number one is, join one of these ACOs. If you haven't joined one, join Charles's, or go out and look to find which one best fits you guys, because you only have until August 1st to get on that train. That's going to be sort of a long-term impact, because like Charles said, you're not going to see a lot of money from this for another year and a half, 2 years. Then after you've got that in place and you're going to start working towards that, you need to, it sounds like from what you said, is we need to Medicaid contracts, our Medicare contracts, because that is a way to create money quickly from that and create value for your patients. I know for me, being old and having a chronic condition, I mean, the healthcare that I get really keeps me around. But I have this whole team that's keeping me going, and everybody, if you're not, because I'm in Chattanooga and have these Harvard-trained physicians that take care of me, that there should be in these rural areas, and these types of incentives are very, very helpful in getting that done. And that's money on the table that for things that you're already doing. It's just a matter of you putting in these proper codes, these CPT category 2 codes, stuff, healthcare you're doing, get credit for it and get paid for it is sort of what I'm hearing. Is that pretty accurate, Charles?
That's exactly right. And it's documentation. So, yeah, we have more worry about documentation. It's true. So it's free money, but it's money available for what you're already doing.
Now, Charles, do y'all participate in helping them with the Medicare Advantage plans, or is sort of your piece of it off to one side, or how does that exactly work?
Technically, right now, we're just Medicare Shared Savings. I'm actively negotiating that contract with Optum and WellCare for our participants.
Mm-hmm.
So that's why Advantage is in our name. What we hope to do is kind of change the dynamic on how our participants are paid for the Medicare Advantage.
Okay.
There are other organizations out there that are just signing you up for Medicare Advantage.
Mm-hmm.
I think some of the things to look out for on those are: how long is the contract? What is the financial benefit to the practice? And what's the benefit to the practice? Yeah. And a lot of those are just Medicare Advantage. We're hoping, we're moving towards melding the three if we include Medicaid MCOs.
Hmm. Is there a quick way for people to know, like, say you have if you look at your PSNR report at the end of the year and it says you've got 1,000 Medicare original Medicare visits on there, and Medicare paid you $100,000. I mean, if you did all of what you're supposed to do for the ACO, you can have this receivable that's going to come to you in a year and a half, 2 years, whenever they do finally settle up with you. Is there a quick and dirty way of just estimating what that is, or is it just this nebulous number that's out there? Something you just don't know what it is.
We get monthly claims data from Medicare that you're going to hear about a population health platform. So that's really how you're analyzing that CMS claims data, this volume of data you get from Medicare on a monthly basis. So those utilization reports that I showed you, we get monthly data that we take back to our participants and say, hey, here's where we stand. You don't know how to directly translate to dollars, but you know how you're performing on annual wellness visits, on readmissions, et cetera. So you're not totally flying blind, but you don't really the dollar amount till after the end of the year.
Okay, but you know that you're hitting the
shared saving. Right.
Okay, gotcha. Okay, and then I got a question from Letitia. Is joining the ACO mandatory? And if is so, is there a deadline and penalties for not joining?
No. Currently, there are no penalties for not being in an ACO. So it is not yet mandatory. Absolutely not. If I implied that, I certainly didn't mean to. What we foresee is CMS says that by 2028, everyone will be in an ACO. That's what CMS says. So we don't know what that looks like in 2028, but no, it is absolutely not mandatory right now.
Yeah, so that number's gone up. They first off started 2030, and now it's 2028 that they want everybody.
That's right.
So okay, well that's
correct.
Yeah, that's good. Well, I mean, and I haven't really paid as much attention to it as I probably should have. But after listening to you today, I was like, wow, I really should have paid a lot more attention to Charles early on, because it's a fantastic revenue source. And like I said, revenue's great, but also, patient quality is so much better too. So I'm looking at the questions here. I think Letitia's was the only one I see in the little thing there. Does anybody have any questions that they want? If you want to, probably not time to type it up anyway. But Charles, thank you very much. We always appreciate you. Appreciate everybody. Thank y'all for coming.
Thank you, Mark.